Right, well, welcome everyone to the February meeting of the NHS Devon Board, which is meeting in public, and especially welcome to a member of the public who's joined us. Thank you very much, Mr. Rawlinson, and to obviously to Sarah, Midgley and Hannah, who are joining us for the citizen story. And also just like to mention that we have apologies today from Darren Alcorn, and very welcome Susan Masters for deputising. Thank you very much, Susan. Bill Shields is also unable to join us, and thank you to Mark Bryce for coming in his place. We also have apologies from Liz Davenport, Steve Brown and Simon Tapley. So just to acknowledge for the minutes that we are quorate for this meeting. But later today we will also be holding a private meeting, and at that we will be discussing the board assurance framework, a delegated commissioning from NHS England, and some matters relating to NHS estates. So come now to the item on conflicts of interest. Does anybody have anything they would particularly like to add? Thank you, Sarah Lou.
Yes, so as well as my position here, I'm also the CEO and founder member of Parental Minds. Parental Minds have been supporting Sarah on her journey, so I thought it was important to highlight that, and also for an agenda item later around the tour-based strategy with SEND. Parental Minds are currently in negotiations with NHS around us supporting a network of parents and caregivers around the First Steps project.
Thank you very much for clarifying that. Does anybody else have any points they'd like to raise? Thank you very much. And then could I just come on to the minutes of the meeting held on the 18th of January? I should note that there have been some typos identified which will be amended in the final version, but are there any other points that colleagues would like to raise? No, thank you. We're going to come next then to our citizen voice, and really very grateful to you, Sarah and Midgley, for coming to share your story, and also to Hannah. I know that you'd both like to introduce yourselves when you start speaking, so if you'd like to make a start, Sarah, thank you.
Okay, well, I'm Sarah Midgley. I attend a group called Parental Minds on a Tuesday when I can go. I've got two sons, one's 22 and one is age 19, and I'm going to be talking about my 19-year-old in this meeting. I'm going to specifically be concentrating on the SEND services in my LA, going through the 0 to 25 team, appealing the content of an EHCP and taking the LA to tribunal, and trying to navigate the NHS services when a child is neurodivergent, in our case autistic.
Thank you very much. I'm just wondering, when you speak, some members of the public following might not know what the acronyms mean. So would you mind, just the first time you using them, just giving a little bit of background about what that means?
Thank you. For the SEND services, so it's special educational needs. LA, the local authority, and the EHCP is the education and healthcare.
Thank you. Hannah, do you want to introduce yourself as well? And then
Yeah, hi everybody. I'm Hannah Pugliese. I'm the Head of Women and Children's Commissioning for NHS Devon.
Thank you very much. So, Sarah.
Over to you.
Okay, thank you. Okay, right, so I've said I'm going to be speaking about my 19-year-old son and the services that we've found ourselves in. So I've got 19 years to try and fit into this 10-15-minute talk slot that I've got. So I will try and concentrate on key issues, and I'm going to have to use my notes, otherwise I will get lost. So I'm going to start when he was 4 years old, and we were in an appointment, and I was finding that there was a big difference. All of a sudden this split was happening between my other son, who was 3 years older, that I was having to advocate a lot more for him in a way that I hadn't for my older son. So I was having to push for things a lot more. I wasn't to be believed. There were long wait lists, only to be told that he's not disabled enough or he doesn't struggle enough. Endless forms, endless questions that I'd answered time and time again, but no one really seemed to be listening because I was just repeating the same things at each appointment. He was in speech and language therapy appointments from birth, really, because they'd identified that he had hearing loss from birth. So we were in speech and language quite a bit at the start, and I was being asked if I talked to my son. Did I read to him? Did he watch lots of TV? Now, my other son had no issues at all with any speech. my 19-year-old has got a very good level of language, he's got very good expressive language, but his language that he receives, he finds quite difficult because he processes it quite slow. So, as I've said, he had hearing loss from birth, but I didn't have to fight for these hearing tests. We were seen quite consistently for hearing all the way through, really, until he got to about the age of 12. He wore hearing aids at that point. He had conductive hearing loss, so it wasn't actually a permanent, but he was aged 4 when he had his first lot of grommets, and before that he had very little hearing, so he didn't watch TV because he couldn't hear. He was using subtitles, and he still uses subtitles now. So at age 4, we went for an appointment to see an ophthalmologist because he was always falling over, he was always tripping up, he was bumping into things, he couldn't navigate stairs, he couldn't walk up and down stairs. And the ophthalmologist tested him and said there's nothing wrong with his vision, he's just not concentrating. He needs to sit still. Now, he was sitting still, but he was looking around the room, and he'd actually said to me in this appointment, I don't know, Mummy, I can't see the pictures. So I said, that's fine, that's why you're here, is to see what you can see, what you can't see. She was becoming quite agitated and quite rude and saying, well, there's nothing wrong with his vision. He is not concentrating, so there's nothing more we can do. You don't need to come back. So I did make a bit of a fuss, and I said, no, I want him tested again. We got another appointment in 6 months, and we saw another ophthalmologist, a different ophthalmologist, who was really lovely. She tested him, and about 10 minutes into the testing, she said, I think we need to do further testing. He saw a consultant, and he was diagnosed with severe long-sightedness. He was prescribed glasses. He also had astigmatism, and they said there's something not quite right about the way he's processing things. But we don't know at the minute what we can do. There's no tests really at this point in time. This is when he was 4, but we'll keep an eye on it. We'll do a wait and see. So that was fine. So we went through that. He was seeing ophthalmologists all the way through. He still sees ophthalmologists. We're not with the hospital anymore. By the age of 14, he was diagnosed as being registered as sight impaired and with a CVI, which is cerebral visual impairment. So we knew all the way along, and he was finding his own ways, trying to navigate. He was trailing his hand along walls. He was falling off the edge of pavements. He was zigzagging across pavements because he couldn't see where he was going. He still finds stairs difficult to navigate, and he is now with the Rovi service, and he uses a white cane. So that's his vision impairment. So I'm going to move forward a bit now. So he's struggling a lot in school. We are managing to see an educational psychologist. We're still with speech and therapy, and he's under the care of a paediatrician. No, none of these appointments are joined up. They're all in isolation. There's no multidisciplinary team, so no one's getting together to find out, because we're in quite a lot of different departments at this point, what's going on. We did have one team set up when he was in school and he was struggling, and only one professional turned up out of 3, and that professional could only stay for half an hour. So it was just me and the Senko at the school meeting. That point, my son was considered a crisis point, which is why we had the meeting. We have various reports coming in saying that he's watching the other children, he's trying to work out what to do, he looks lost, he's withdrawing into himself, his self-esteem is really low at this point, and he appears very anxious. He's hiding behind books when he's on the playground at school because he can't cope with all the vision and the noise. He's curling up into a ball. So now I would know that this is all self-regulation that he's learnt to do himself. In all this time, though, unfortunately, he's blaming himself that he can't cope. He doesn't want to go to school anymore. He hates his time there. He keeps asking over and over, what's wrong? Why doesn't anyone like me? Why don't I get it? He's getting bullied. He's got no friends. Some staff are telling him he's not trying, he's not working hard enough, he's choosing not to do the right thing. But his behaviour is said to be exemplary, which it is. He's never caused any trouble at school. He's never kicked off. He just withdraws into himself more and more. So as a parent, that's really tricky because we're trying to get the help, but everyone's saying, no, he's fine. He's fine in school. So at this time, he's getting to about the age of 10. We asked for him to be considered for the autism pathway. And the paediatrician says, no, he's not autistic. It's his hearing. That's why all his communication issues, it's all down to his hearing. But we've joined a hearing impaired group for children, and he's not the same as the other children. They're still talking, they've still got friends, they're interacting. He's not, he just wants to be on his own. So a year later, we go back to the paediatrician, we compile lots of our own evidence, and we say, no, I would like him to be looked at for autism. We're just, as a family, thinking there's something, not quite right, what's going on. He does eventually get referred, and then we're on a waiting list for 3 years, so another 3 years at school of failing and not coping while we're waiting, and he's diagnosed at 13 as being on the autistic spectrum. So for us as parents, it's just been horrendous to this point, watching him get further and further behind with his education, and he's blaming himself still. So I'm just going to move forward a bit now. So between the ages of 11 and 15, the paediatrician, who's been excellent, he has been really good, he's been trying and trying to get my son referred into services because of his anxiety. He refers him twice to the learning disability nursing team. Both of those are rejected. This is over 4 years. Once to a clinical psychologist for an assessment and CBT therapy, and that comes back as a no. 3 separate CAMS referrals in those 4 years, all no. And once into integrated children's services, no. So I've had to be quite proactive too. I've been ringing departments up. I've been explaining the effect this is all having on him. He's almost at the point now where he can hardly go into school. The clinical psychologist was really nice. I rang her up and she finally agrees to see him, but she makes it clear it will be 1 session and only 1 session only. That's it. If he gets worse, he's got to get worse, they would consider a referral. The reasons not to accept these referrals have been he doesn't meet the criteria, he doesn't meet the thresholds for support, he's not disabled enough, no clear evidence of any mental health problems. Once we got into CAMS, once he got his autism diagnosis, we were trying to get into CAMS, they said, well, he's autistic, so he's anxious, we can't see him. So now my son's barely attending school and there's still no access to help. The paediatrician's apologetic that services aren't there for us, and it's becoming increasingly obvious to us that we're being bounced back and forth between the departments, and it's just a time-wasting exercise, or so it seems to us. Now my son's ill mentally and he cannot attend school at all, and he spends year 10 at home. He doesn't leave the house, he finds it hard to communicate with anyone. The LA is saying he's got to go back to school, there's nothing wrong with this school, he can cope. We get threats as parents about non-attendance, and I refuse to deregister him because I know that if I deregister him, that will be it. We'll be out of all services and he will not get back into another school. So roll forward now to 2019. My son starts, without telling us really, he goes about 6 months without telling us that he's having all these intrusive thoughts about being schizophrenic. So he's not just having thoughts about being schizophrenic, he's researching online all through the night, day after day, constantly, because he thinks there's something going wrong. I'm having these intrusive thoughts, it must be me. What's going on? He's getting really scared, but he's not told us. We're noticing that he's doing these odd sort of behaviours. He's doing rituals, which we know now. So he's having to walk around a tree so many times. If we take the dog out for a walk, he's got to do it 23 times. If he gets stuck or something happens, he's got to start again. He's got to walk 23 times round. He's having harming thoughts. So the thoughts are saying jump out of a window, jump off of cliff edges, jump down the stairs, do all these things to harm yourself because you're wrong. You need to punish yourself. He can't sleep. It's taking him 4 hours to get to sleep most nights because he's got to change everything in his room. If he gets interrupted or he does it wrong or he thinks he's doing it wrong, it all has to go back in again and then all back out again and do it over and over again. Everything must feel right, mustn't feel wrong. He mustn't make any mistakes. At this point, we're just not sure really what to do. He's 17 and we just trying to get him out of the house is very difficult. So we visit the GP. I try and convince him to go to the GP. GP's really nice. We're seeing him on a wet November 5:30 appointment for 10 minutes. He's saying, well, we can't rule out schizophrenia in front of him. You need to see a child and adolescent psychiatrist and we need to refer you to CAMS again. But I don't think you're going to get in. I will put it through as an urgent referral. But he hasn't made an attempt at suicide and the criteria is now higher to access this service. I can't leave him alone in the house at all now, even for 5 minutes. I've got to be in the house with him because of the constant harming behaviour, and I've no idea what he's going to get up to. Luckily, I'm in Sainsbury's of all places, and I bump into somebody I knew from a group that I'd been to a couple of years before, and we just were having a general sort of chat, telling her about my son's difficulties, and she's seen a psychiatrist privately for her son, different set of problems, but she can't also access anything. So I get the details and I decide that there's no other options and we're going to do this too. And at age 17, he's diagnosed with OCD. He continues to see the psychiatrist now, and he also receives CBT and ERP, but privately, because we cannot access anything in the NHS. But at last, we're getting consistent, good quality care. And this isn't a bashing thing about the NHS, because we have seen some really good people, but there is nothing there for him. So we have no option. He's either going to completely go downhill, or as a family, the onus is on us to do it, and that's what we've done. And we're lucky he gets PIP, and we use that money from his PIP. He knows, he's aware that we do that, because we don't have private health insurance. We've never used private services before, but there is nothing else to do. And we just can't. Luckily he's still here. He didn't harm himself really bad, but who knows. So I just really now quickly want to mention about the tribunal service. So we had our hearing last November 2022. I did not want to go to tribunal at all, but it got to the point we had no choice. The LA had refused to add the content to the draft of the EHCP, the Education and Healthcare Plan, and we needed more support now he was 18. He was in college and he was attending, he was managing to go in, even with everything going on with the OCD. And he'd had his EHCP since he was 8, but it did need updating because it had nothing about the OCD, nothing about the mental health. It had needs about his vision, that he was cane training now, so none of that was in there. The LA said, no, we're not putting anything in, it's okay as it is. I think one section had one outcome for him for post-16. So we went to tribunal. In my opinion, it was a complete waste of time. I was still having to look after my son. He was really quite ill still at this point, over a year ago. And the whole process took about 8 months, and it's a lot of work. So 4 months into the appeal, the LA agreed to add about 80% of what was needed. So after 4 months, we got 80% in, all the stuff that we'd said. I had all the evidence, we had all the reports. They wanted then for us to go on the papers and to strike it. That was it, to the end it. But I said no, because we've still got other things that were important, mainly to do with his vision. So we had reports. He can't track traffic, he can't track things moving. So crossing roads is very difficult for him, and I wanted things like that left in his EHCP. With all this going on, the communication is still very poor from the local authority. They don't share important new evidence with us or the judge, and all the way through the tribunal you're told that once you get the appeal is agreed, that both parties have to share information. So if I get any new evidence, I have to share it with the LA and I have to send it to the judge. The LA have to do the same to me. Now, this didn't happen in certain points in my experience of the tribunal, and they added information without my knowledge in this working document. This working document goes back and forth. And then at the end, when you get this massive big bundle, which goes obviously to the hearing, they'd left out important evidence, and it was actually the evidence from a professional that had given the vision, his part about the vision. You're supposed to look through this bundle, you're told by the judge to look through the bundle, make sure everything's there, which I did. I double-checked it. This document wasn't in there, this report. I contacted the LA and said, why was it not in there? There was no real explanation. They said it would be disproportionate to issue the bundle again. It was going to tribunal with that bundle. I then informed the judge that this had happened, and they said it's up to the LA to resolve. So the onus was back on them, but they wouldn't resolve it. The bundle went to the tribunal. I did send the judge the evidence, but I wasn't sure at that point whether the judge would actually use that evidence or whether they were just literally going to do that hearing on that bundle. So it went to hearing in November, and the judge ruled in our favour. We got 100%, everything had to go in. and they were to finalise the EHCP within 5 weeks legally. So we get to 4 weeks, still nothing's happened. We get to 4 weeks and 5 days, still nothing's happened. The college contact the LA, I contact the LA, thinking they're not going to issue this EHCP, it's not going to get finalised. The tribunals say it's nothing to do with us anymore, we've done our part, it's now down to you and the LA. If they don't finalise it in the legal time frame of 5 weeks, then I would have to put a complaint in. If we don't get that resolved, I have to go to the LGO and start another complaint or do a judicial review. That means I would have to have a solicitor. There's no way we can afford a solicitor. So I'm researching all this. We get to 4 weeks and 6 days. That evening, they send through the amended EHCP, the finalised EHCP. We ask why it took such a long time, and I'm told we missed the email from the judge. So not only have I waiting 5 weeks for this tribunal, for this amended document to come through, I'm still then having to research, and this is what I've done all through the tribunal. There is no help. You try and get DIAS, the Devon Information Service, which is supposed to be great, but they've got massive waiting lists, and I've got to get my stuff done within timeframes. So you can't even, get through to anybody. So with the tribunal, you do it all yourself. I look online, I see what other cases, how have other people done it, how have they filled out the forms. The tribunal service itself, apart from them not making the LA put the document in that was missing, I haven't got any qualms with. It's a good service, it was good, but it's very lengthy and it takes an awful lot of time. And I don't have any legal background, I don't have a team of admin doing all my stuff, it's just me. So that's about the tribunal. And then I just really wanted to say, a friend said to me afterwards, she said, oh, you've won, wow, all that hard work. But I disagreed. I said, well, what have I should never have had to do this in the first place. All we wanted was a well-written EHCP that would reflect his needs. Now he was 18. I've just had lots of extra stress and time commitment. And I think this is happening over and over again in Devon. Parents are getting very, very fed up, and it is ruining lives. I just wanted to say, when the lockdowns happened and all these children were out of education, all these parents were saying, the children that could be in school, that were accessing school, that were okay, they were outraged. How awful, how damaging it was that their children weren't getting this education. Got to do it all online. There's thousands of children with special educational needs or barriers to attending learning that aren't in education. Now everyone's back after the lockdown, no one's bothered again. It's okay. All these kids are still not accessing an education. It's mind-boggling really. And then I just wanted to say about the group that I attend, that there's people coming, all these people coming with children younger, and it just seems the services are, in my 15 years that I've had with my son, they're much worse. People are now having to do speech and language assessments on Zoom. My son would never have coped at the age of 4 of doing speech sounds over a Zoom. I just can't see how that's quality at all. The waiting lists are getting longer and longer. There's kids trying to get early help and they're still on the waiting list. They start school, they're now too old to get this early help. There's no educational psychologists at the minute. There seems to be a massive backlog with those, and lots of children just getting missed. And I just can't believe it when I go to these meetings. And I just want to wrap up really to say that little did we know when he was 4, that was how the next 15 years were going to be for us. And if you're lucky enough not to be in this system, you have absolutely no idea. Friends of mine that know me quite well say, I just can't believe what you have to do. It's like living parallel lives. But for my son, I think all this psychological trauma isn't just about what's happened to him. It's about how it's made him feel and how he's made sense of that, and he blames himself. And the OCD that he has, it's all about uncertainty, it's all about shame, not doing things correctly, and doubt. And instead of feeling safe, he just feels that he's never going to be okay again, really. He's trying to go to college, but he has to work through about an hour and a half before he can leave the house for these ERP exercises, because most of his themes at the minute are, well, if I go in, I'm going to do it all wrong, or maybe yesterday I did everything wrong, so what's the point in going in today? But if we don't work through the ERP, then all it's doing is making the compulsion worse, because it's like, well, yeah, don't go in because you're going to do it all wrong.
Thank you so much, Sarah, and to your son for sharing your story with us today. And I'd just like to start by apologising on behalf of all of us for the terrible experiences that you've set out so powerfully today. And I know there will be lots of questions for you. And I'm very grateful as well to Hannah for coming today to try and actually talk to us about what we're doing to address some of the things that have been set out so starkly by Sarah. I'm just wondering whether it would be better for us to have questions from around the board table first to Sarah that you could then incorporate a response to, that would work best. So colleagues, can I ask, is there anybody who would like to come in? Frank.
Sarah, I'd just like to say thank you very much. I have a huge amount of empathy with your situation. I've got 2 children who have learning difficulties, and I've had to go to tribunal. One of the tribunal, in fact, I've gone to tribunal twice for one of them, because the LA used the information we had against us in legal argument to delay the process. I fully understand what you have been through. It is the reason I'm on this board, and I assure you I will do what I can to try and improve it for all the children and all the families of those people who are suffering, because we do suffer. For one of those tribunals, we put together 700 pages of information that we have collected over many, many years. We basically didn't get listened to. Services weren't provided, and the obstruction that Sarah has articulated, I have experienced personally. And it still impacts on me every day, as you can tell from the emotion in my voice. One of my sons, who I asked for early help, did not get it at the age of 16. Yesterday, he was stabbing himself in the neck to try and kill himself. He's 25, he's got a drug problem, and it is ongoing. He gets to the emergency department, they discharge him to the mental health system. The mental health system has re-discharged him back to his accommodation. So the situation, if we do not help these people early on, and if we do not change the culture of how we interact with them, we will be creating problems for the whole system for a very long time. So thank you, it was a really powerful presentation.
Thank you. And we've got Sarah Lou and Hisham to come in.
Sarah, I just want to say a huge thank you for raising this today. And I think you can probably observe there are several members around this table that are actually struggling at the moment. I didn't expect me to be one of them. I'm just really proud of you for bringing this up. We have to change. We cannot let this continue happening time and time again. We have to really listen to what Sarah said and look at the emotion that is around the room today. And it's a very powerful day today. And I hope that this starts a really serious journey about getting children, young people, mental health very firmly on the agenda and keeping it there at the highlight. And we need to keep coming back to what's happening in this room at this moment in time.
Thank you, Sarah Lou. Sarah Lou, it's Hisham.
Sarah, thank you very much for your presentation, which is very humbling for all of us. I just want to go to the pre-tribunal part of your very troubled journey with lots of challenges and barriers, and just want to highlight the lack of integration of care, which you've highlighted in a very clear way, and I believe that is an area we need to focus on. It's part of the reason why the Devon Integrated Care System exists, for integration of care and coordination. And the fact that you've mentioned appointments completely disjointed is something that should not happen. And the fact that there should be some sort of a coordinator or support person for the family that's going through such horrendous journey and challenges. But thank you again.
Thank you. And I know Tandy, who's joining us online, has a question. Tandy.
I don't know if you can hear me, because I think the line today is pretty broken up. You can?
Yes, we can hear you, Tandy.
Okay.
Thank you.
Yeah. Thank you very much for your story, which is really, really powerful. And I think that I have to say that I almost sort of identify with that full journey that you have gone through with my own daughter. In particular, the need for the parent to almost be a warrior for their child, and feeling like you have to fight at every stage to get basics put in place. The base around psychology and language, I mean, I have struggled with that, and I'm pretty sure that a lot of people out there are struggling with it. But I suppose that this also sort of just tells us about why these systems working that we're trying to put in place is really, really important. In particular, for me, the provision outside the clinical space. I mean, my daughter's only started attending an autism club last year, and the difference in her being able to have access to something that isn't in school, which she absolutely hates, but also to connect with children exactly like her, is huge. Um, and so, although it's sort of really frustrating that many of those experiences cannot be changed at the click of a finger, but I think it just highlights why we really do need to push a lot around these systems kind of working, as well as looking very carefully at the non-clinical end of provision, which in my view, much of it is a lot cheaper and a lot less, a lot more effective than some of the ways that we're trying to deal with, particularly children with these sorts of needs in some ways. So thank you for bringing your story here. It's really powerful. And I'm really sorry that the system hasn't been able to help you sooner than it should have.
Thank you. And I've got questions from Tracy Lee, from Kate Shields, and from Judy. So, Tracy.
Thank you very much, and thank you so much for sharing that story. I think it's just such a powerful story, and just articulates how much we have to do as a system. And on behalf of local authorities, I just want to say I'm sorry to go through what you've been through and what your son and family have been through. I just wondered if you could say a little bit more about the schools and when your son was in school, and anything that you think. Obviously there are a lot of services that fail to be there. In terms of schools and the support that you were able to access through the schools.
Thank you. Yeah, I'm trying to think really. So he was mainstream all the way up until year 8. So when he started school, there was obvious problems. And the school applied for an EHCP when I think he was about 4 or 5, and then it came back as a refusal to assess. At that point, as a parent, I didn't know the system at all, and I just thought, oh, well, he will get the help in school. So we left it. We just thought, yeah, okay, they've made that decision. That must be the right decision. He then got put in again for an EHCP when he was 7. I think when he'd started year 3. And that one got accepted. So from the age of 8, he actually had an EHCP in place, but it was only for some help with English and maths in the morning. So for the rest of the day, and more importantly, lunchtime, which is what he found the most difficult, or any break time, any free time, he was just left on his own. And because he had no behaviour difficulties, he wouldn't shout out, he didn't cause any fuss, he didn't tell people he was struggling, although it was quite obvious that he was struggling with things he was doing. He was just, shutting down. So we didn't actually get, that was it really. And then he went to secondary for year 7 in a mainstream, which they were fantastic. We didn't go to our local secondary because it didn't have a big needs base. So we went for a different one, which I had to do all the transport for because it wasn't our local one. And they were fantastic there because they had a separate base that helped children. Although he wasn't diagnosed, he did have needs, and they were quite obvious needs, but it was becoming apparent that as he got older, so by the time he got to year 8, he just was not coping at all. He was getting bullied, he was getting picked on because obviously he was quite different. and it just became apparent that he was spending all of his time in this base rather than some for support and then going out into the mainstream parts. So we then had to fight to get him into a specialist setting. That specialist setting didn't work for him at all. There was a lot of behavioural issues there. My son doesn't have behavioural issues, and he didn't like all the noise and all the just, you know, I'm not going to say violent, but things that were going on at the school. He just couldn't cope in that environment at all, and that's when he came out of school. So, yeah.
Thank
he
you.
was, very hidden.
Now, I know there are 3 other colleagues that would like to come in, but I'm also very conscious of time, and I know we're all keen to hear from Hannah as well. So can I bring Hannah in next, and then Kate, Judy and James McInnes, who I know are also keen to come in. Would you forgive me if we just come to Hannah next, because I think it's important we hear her response.
Okay, hi everybody. So I've got a few slides that the clicker doesn't. Oh, there we go. And you'll find that through these slides, I'm going to be quite quick and happy to circulate them afterwards, but you'll find through these slides that a number of the things that Sarah talked about come through in the slides as well. So we have undertaken a review of the community children's services and the neurodiversity pathway, and my slides focus on both special educational needs and disabilities and neurodiversity as a specific element of that. Found very similar things to the situation that Sarah has described. So bit of a fragmented system, pathways stretching across different services and not talking to each other very well. An increase in demand, definitely a theme around our structures and our definitions of referral criteria don't work very well for families, and that in doing that we often increase the fact that families have to fight because they're trying to navigate our system. A focus on diagnosis rather than need. So trying to get people through diagnosis as a way of accessing support. And one of the things about that, I think, is that the system outside of health views health as a way of unlocking their understanding of what children and families need. Does that need to be a full diagnosis, or can we do that in a slightly different way? So I think I won't go through all of those, but and I'm going to come on to some of the points later, but that was just an overview. The other thing that I wanted to do, and thank you, Frank, for raising this, is to draw the the connection between special educational needs and disabilities and families. You know, if we think about that in its broadest sense, it is all children who have an additional need that impacts on their ability to have their best possible life. Their ability to learn, their ability to achieve, their ability to move through the education system in all of its capacity, social and educational. And we know that there is a real connection between special educational needs and disabilities and health inequalities and inequalities in general. And this slide just pulls through some of that. And you can see that some of the areas that Sarah talked about are here as well. So this is actually Torbay data, just because I had it to hand actually. But there would be similar data for Plymouth and for Devon as well. So we know that for example, between the top 4 primary needs, they account for 82.6% of special educational needs and disability support, which is speech and language and communication and social, emotional and mental health and autism, because that's the way it's categorised. But I think, you know, if we think about the spectrum of autism and ADHD being a kind of continuum and describe that as neurodiversity, it's a helpful way of not excluding people who haven't already received a diagnosis. So this is just an overarching picture of where we're at as a system in terms of special educational needs and disabilities. So we know that the Devon local area was re-inspected and it was found that we hadn't made sufficient progress in any of the 4 areas that were identified there. Torbay had their first inspection, and 8 significant areas of weakness were identified for Torbay, and we've got the strategy for Torbay later on the agenda this morning. And the really significant thing about the Torbay inspection was that the 8 significant areas were very much across the local area. They didn't pull them out as being a health requirement or a local authority requirement or an education requirement. It was about that integrated culture of working together. And Plymouth was inspected right back at the beginning in 2016, shortly after the reforms were launched. But we know that an inspection is due in Plymouth sometime relatively soon, and that plans are already being worked on to make sure that we're ready for that inspection, but more importantly, that we're already undertaking that improvement work together. So this slide depicts something that we call the neurodiversity game changer. And what I want to say about that is that this is a piece of work that has some short-term, quite significant ambitions, but also we know that this is quite a long-term piece. Because again, if we talk about neurodiversity being that broad, anybody that identifies themselves as not being neurotypical, if you like, then that does help for us to be a bit more inclusive. And we have some really key opportunities. So we have an opportunity with some funding that's coming through from the South West Provider Collaborative to create some key worker posts that will work at the earlier end of the pathway, so that will be introduced. It's only a year's funding, so we need to be really good at evaluating this pilot. But that will be able to be support at the point of need rather than the point at diagnosis. So the key workers that have been in place so far have been about avoiding admission to hospital. These key workers will work at the other end of the pathway. And it brings in a bit what Tandy was saying and what Sarah was saying about if we can help earlier, if we can do things that are not necessarily based on kind of senior clinical input, but are about working with the whole family in a relational approach. That's the idea with the key workers. And then creating a holistic neurodevelopmental assessment pathway is about reducing some of the fragmentation across the services that we see at the moment between community paediatrics, CAMS and nursing and therapies, so that we overcome those organisational boundaries and we don't expect parents and families to. So those are the 2 pieces of work that are moving forward really quickly. We're working with Exeter University on some research and evaluation work around all of that. And there's an ongoing piece of work with the providers of these services to look at demand and capacity as well across neurodiversity and speech and language and communication. And then I've just popped this slide up to show you the breadth of the SEND work that's already happening across the whole of the system with each of the 3 local authorities and with the health system. And you can see that, again, that pulls through a lot of the themes that came through in Sarah's presentation. So strengthening the culture of working together, looking at how joint commissioning can facilitate that, looking at upskilling professionals who are working with children and families and really valuing that lived experience. I mean, 2 of the things that came through really strongly were the not listening to parents and parents feeling blamed for the situation that their children and families are in. And there's an awful lot of work going on around changing that culture so that we do listen. Making sure that SEND isn't just confined to this kind of process that sits over there in the local authority, but is everybody's business, that we think about children in that more holistic way, helping them to live their best life. Co-production being absolutely at the core. We won't get this right without that. Communication, and that came through again in Sarah's talking, using common language, making sure that things are clear. Making sure that our graduated offer is clear. So where health do need to unlock the understanding around a child and family, that schools and settings and social care and early help are enabled to be able to put those interventions in place. and more focus on outcomes. So how do we know we're making a difference? One of the things I think we could be doing as an ICB around that is to be looking at some of the SEND data here, some of the local authority data in the health service. That would be a really good way of understanding whether or not we're achieving some of the outcomes. It's quite a practical thing, but it might be really helpful. And then unlocking capacity and making best use of resources, so working more smartly, and the integrated pathway is some of that work. I do absolutely agree with what Tandy was saying about services that aren't necessarily based in clinical teams being often really helpful, and we've got some really excellent examples of some of that work happening with our voluntary and community sector organisations, including Sarah Lou's organisation, but also Young Devon is doing a brilliant piece of work at the moment supporting children who are admitted to paediatric wards, building relationships with them and supporting them when they go home with small personal health budgets to help them integrate back into their communities. So there's quite a lot of work going on in this space. I've rambled through that really quickly, but I was very conscious of time, and I'm very happy to answer any questions that people might have.
Thank you very much for that really concise presentation. I know you're going to share the slides with everybody as well. So I know, Kate, can I ask people to be as brief as possible because of time constraints? So if I actually take a question from Kate, Judy, and then James, and then we can see who would feel best placed to respond. So, Kate.
And sadly, the description of what's happened in your life, I've heard from several people last week around what's happening in their lives, and the common denominator is hearing families. Not saying that we're listening to you, but actually hearing what's being said. So I think some of the work that you're doing, we'd like to nick, if that's okay, so that we can try and align the offer across the peninsula rather than just in certain parts of it. And I am mindful also of the specialised commissioning, where lots of people have got syndromes or spectrum presentations, and they're really hard for us to manage in a health and care way, because we like people neatly packaged, meet the criteria for our services. There is something here about how we use the voices of families to fundamentally change the way that we work. So if there's anything we can do to be part of it, we'd love to be, and that's a little hard one to get into. And thank you for a really honest and clear description of everything that didn't go well.
Judy Hargaden.
Thank you very much, Sarah. That was extremely helpful to all of us, and brings up again this issue, which perhaps Hannah can come back to us at another time. But I just wondered how much time we waste saying no, how much assessment is done. And it would be really good to do just a small sample. We don't need to spend hours on it, but and it must be destroying for some of the professional staff too, let alone for the families and their children. So I wonder if at some point we could come back to that.
Thank you, Judy, and of course a huge cause of widening inequalities, I think, as well as the waste of resource. Councillor James McInnes.
Thank you, Sarah, and I will be brief because I really appreciate, chairing the meeting's not easy. I just needed to say to Sarah, thank you very much for coming to the board, like others have said. It's a very emotional journey you've been on, and as a county councillor in Devon, I'm very well aware of the issues and the special educational needs. And we had a demonstration at County Hall last week of over 250 people. About special educational needs, and I'm really pleased that we're here today at the ICB discussing it, because this is a whole system thing. And for me as a lay person, the later presentation about what we're doing about it, I was really pleased to hear that we're recognising that families and children need support before they get diagnosis, because a parent and a child are experiencing the behaviour and the trauma regardless of getting a diagnosis. And so we really do need to be in there early, and I'm pleased that we're working on that. Thank you very much.
Thank you. I think it's a measure of just how powerful your story has been and the importance of this issue for all of us around this table. that we have unfortunately gone way over our time, and I am going to have to bring this section to a close. But I'd just like to assure you that we will be returning to this. We don't see this as a one-off, you coming to share your story. We see this as a way of focusing all of us on just why it matters to so many people out in our wider community. And I want to assure you that there is a real commitment to take an approach to this that isn't just looking at health in one area and local authorities or education in different silos, but to try and see as one of the purposes of having integrated care systems is to make sure that we try and join up what we do. And so I will be returning to this and will be in touch with you after the board meeting, if that's all right, to see how you would like me to follow up with you. Thank you again for coming, Sarah. Thank you. Right, so we're going to come on now to the section on leadership, and I'm not going to say anything about my chair's report because I think it was important that we spent the time listening to our citizen voice. But Jane, was there anything you wanted to add to your chief executive's report?
I've got loads, but anyway, time is probably a challenge. I suppose a number of items on my report actually feed into some of the things that are on the agenda at a later stage, which obviously includes the urgent and emergency service recovery plan. Just to say, we are expecting one for general practice at some stage soon, so we'll be sharing that with colleagues. The other thing I just wanted to say is in relation to the operating plan, we are in the process of bringing that together for our draft submission, which is on the 23rd of February. Quite a lot of work, and to thank you to teams across the whole system, really, in relation to that. And also, we are linking in, I think, more with our local authority colleagues to ensure that we've got sight of their operating plan or budget setting. One thing I would say, though, because we are a system that is in what's called SOF 4, a System Oversight Framework 4, and an unusual system in the fact that both the ICB as well as our 3 acute trusts are all in SOF 4. That means that there is an extra level of scrutiny. So after we submit our plan on the 23rd, there will be a follow-up meeting, a board-to-board meeting with colleagues from chairs and chief execs across Devon, and a number of people who sit on the Devon ICB, meeting with NHS England board, and that's on the 9th of March. We will be obviously reporting back our progress to date, but also, I suppose, identifying the future work that will feed into the submission on the 31st of March. We will, at that meeting, be signing off our exit criteria, so the things that are the must-dos for us to achieve moving into SOF 3, 2 or 1. And I will, those are in draft at the moment, but I will be sharing those with colleagues after this meeting, but actually we'll need to bring that back to a future board meeting. That will also give a framework in terms of our BAF as well as our shaping our priorities. I think it's fair to say, though, that a lot of this we will have to try and find the balance to ensure that we are getting a true population approach to our priorities going forward. But there is this tension whereby we are required to have in place recovery plans, particularly for a number of our acute services. The last thing a couple of other things I want to say is that we have shared with board members outside of this meeting, and we will do, I think, more publicly. Our staff survey this year was very positive. We had a lot of very good feedback, but we also recognise we've still got areas that we need to hear our staff and work on that. So we've started a number of face-to-face meetings to supplement our normal staff bulletins, and I think they've been well received. We are still expecting at some stage some confirmation of our running cost allowance, which will mean a change on how we are able to do the business that we are required to. And Kate and I have already started to meet to talk about actually where are there duplications or opportunities to work across across the peninsula, and we've just talked about one example where it doesn't make sense for us to do things separately. So further work on that. And I suppose the last thing I will say is, I mean, today's citizen story, and thank you again to Sarah, is a way we want to frame it, so we're actually able to make the link between our performance, our what we're hearing, and what it's actually like for both patients and families and staff on the ground, and then what we're doing about it. And I don't think we've yet quite got into the rhythm of that in terms of the sort of the transformational levers that we need to collectively pull. And that's not, you know, just sitting in one part. That's why we have the Integrated Care Partnership as well as the Integrated Care Board, because as all, you know, pretty much everywhere, it's not just one part of the system that tries to solve it. It has to be a joint effort. So quite a lot happening, and to say thank you to everyone who's been working so hard, particularly at this quarter of the year is always really full on. So thank you to staff and colleagues, and a number of you, well, all of you are involved with that. So thank you.
Thank you very much, Jane. So could I ask colleagues if you're happy to note both of those reports? Does anyone have any burning questions at this stage that they would like to ask Jane? No. Great. So we're going to come on next to Devon Workforce Challenges and Paul Renshaw. Thank you very much.
Thank you. So this has come to the board this month following a request from the board back end of the last calendar year. And what we've done is summarise all the many and varied challenges that we've got from a workforce perspective. Clearly we talk about workforce a lot at each of these board meetings, but I think it was just a good idea to kind of keep everything in one place. All the work that's described in the paper is part of our One Devon Workforce Plan for the year, which is a health and social care plan. We have a monthly executive workforce group that sort of sets direction and scrutinises performance. That's then also overseen by our People and Culture Committee that's chaired by Tandy, and this paper's been through that committee as recently as last month. We've got 4 pillars of work, and those 4 pillars all align around the kind of 4 issues that we've identified as particular challenges. I am conscious of time, so I'm hoping that people have read the paper, and if you've got comments, then that's absolutely fine. I think simply to say that, you know, we've got multiple challenges wherever you look, and we are sort of no different to a greater or lesser extent than most other health and care systems. It's been a really tough 3 years for our workforce. And I think, you know, what you're seeing in here is a reflection of that, and we shouldn't underestimate that. We're doing a lot of work on recruitment, and it's great to see that we've got a number of activities that have been ongoing. For example, our international recruitment work for health and now social care that's bearing fruit. We've just launched a system-wide medical recruitment campaign, so it's the first time we've had that. So all of our providers have come together, and we're doing a One Devon campaign to try and encourage doctors to sort of join us in Devon. So we'll see the fruits of that, and an early focus is on DPT, because we consistently have consultant vacancies that are pretty difficult to fill in the kind of normal ways of filling them. The other thing that the recruitment arm is looking at is the extent to which we can have a different model of recruitment, particularly for social care. So we've had a fabulous pilot within Livewell, and Plymouth City Council are continuing work in that arena. And it's really focused on how many people can we encourage to come into social care roles that perhaps haven't thought of that as being a career. We've got approximately 13,000 people who aren't working and who are claiming benefits at the moment. So our challenge is to find as many of those people who are suitable to come into those roles, And there's a business case that we're looking at the moment to try and replicate the kind of Livewell and PCC work, but across the county. So I'll pause there on recruitment. Agency costs, I have to say, actually, I mean, whilst we're spending more on agency than we'd ever like, and more than last year, we are in fact the lowest user proportionally of agency across the South West, and a very good performer nationally. That said, it's still not a small number, so a lot of work has gone on so far, particularly around agreeing new frameworks, which are basically a way of managing our agencies better at lower cost. So we've got a new nursing framework, and the framework for medical and AHPs comes in at the back end of this financial year. We've always had, well, for the last couple of years, a medical locum bank that's working reasonably well, but more work is on with strengthening that. And I'm pleased to say that we've got agreement in principle to have a kind of a collaborative bank for all staff groups that's managed in the same way, in a consistent way, across Devon. That's going to start with nursing early in the next financial year, and then quickly move on to the other clinical roles. And we expect that to drive a lot of cost saving, which is clearly an important aspect of what we need to focus on. Health and wellbeing, we've got a sort of deep dive on this coming to the People and Culture Committee in May. We've looked at things like attendance rates for quite some time in Devon. Habitually, the system has been about 0.5 percentage point higher in its absence rates than the national average. And we've looked at this every which way is up. And we've had the region, we've asked the region for help and the national team for help. And actually there's no big issue that's flagging that makes us very different, which makes it harder to solve. So anyway, we're sort of reviewing our management practices at the moment. We've had a wellbeing hub in place since the start of the pandemic, which we are keen to continue to have next year, although that has to be funded from within our system rather than having sort of external national funding for that. But we're really clear that the route through a lot of our challenges is to look after our workforce even better than we have done. So not complacent. It's not entirely clear where the issue lies. You know, we've looked at things like whether or not it's our age profile, and it's not. And there's no particular staff group, so there's an underlying issue there somewhere, which we are looking to get to the bottom of. And then finally, again, many of the problems we have are associated with not having a great workforce plan and not a great workforce planning tool, and not having a workforce strategy that properly describes the size and shape of the workforce going forwards. We are towards the end now of designing our own workforce planning tool. There are tools out there that we could buy. They're very expensive from commercial partners, so we've chosen with Health Education England to build our own. We've got high hopes for that, and at the point that it starts to work properly and gives us some good intelligence as to what to do differently, which will be the first half of the next financial year, we then have agreed to obviously share that with regional colleagues and clearly our colleagues over the border in Cornwall as well. So that will be a first for the NHS, because actually there isn't a workforce planning tool that the NHS has created for itself, which is a huge deficit. And then finally, we are just putting the finishing touches to the workforce strategy. So board members will receive an early draft of that in March, and that is to describe the kind of intent and how we wish to see we enable our workforce to work differently going forwards. I mean, the issue at the moment is that we've got people exceptionally busy and at the same time we're spending too much money on staff, and the two things clearly don't coexist nicely. So the aim of the workforce strategy is to ensure that we have a clear direction of travel in terms of the size and the skill mix going forwards, and that we actually find ways of enabling our colleagues to give their best at work every day. And I don't think we're helping them to do that at this particular point in time. So you'll see the narrative as board members in March. We then will have a sort of financially sort of driven plan for board to look at sometime during Q1. That's all predicated on us having agreed the financial strategy, you know, at the sort of, you know, high level to begin with. So that's the plan for that particular piece of work.
Thank you very much, Paul, for that presentation and a very detailed paper. And we'll look forward to discussing we have much greater time at the board to discuss the strategy when we receive the draft. Yes, Graham.
Thank you. So, two questions, please. The staff turnover, I know it's a pretty universal challenge, but you haven't really talked too much about, have we really got to the root cause of that? Because, you know, the bath is being filled from a tap at the top, but the plug is there, empty, going out. So, question, what can we do about that? Have we got enough granularity of understanding what's driving that turnover, without which addressing it will be tricky? That's question one.
Yeah.
And I guess my second question then revolves around the triangulation question. So we're struggling to deliver the services that we would like to. We are over budget, and yet we're under capacity on staff. So how does that factor into your thinking about how we recruit and yet improve productivity at the same time? Please, thank you.
Okay. So we do understand our turnover, and we understand where people are going, and quite a chunk of that is retirements. And what we're seeing is that we've got a sort of bow wave of people who didn't leave during the pandemic now deciding to leave. So a number of people sort of stayed with us through that particularly difficult time. You get, when you look at our data, we do have some movement within the system. So when you look at the headline turnover, for example, for nurses, it says we've got a 13% turnover rate when you add it all together. In fact, actually leaving the NHS, it's about 7%. There's a reasonable amount of movement in between. So it's important that we look at the kind of the net loss. Like I say, about half of that is retirements. You get work-life balance as other issues, as well as just, wanting to find a different sector to work in. So trusts do exit interviews. We've got a particular piece of work that will continue into next year around retention. And that's focused particularly on nursing retention in the first instance. But, as we know, a lot of people don't leave the organisation. They leave the line manager that they have, and that tends to be where, relationships are sort of, either fabulous or completely broken. So we understand, where people are going, why they're going, but, you can't underestimate, I don't think, the impact of the last 3 years of, sheer hard work and effort. So there's a lot of burnout going on there, and people are deciding to retire, earlier than they perhaps would have done. So that's the issue around retention. In terms of the workforce strategy and productivity, what will be baked into the actual plan is something that is a formula that gets us to a place where we get back our productivity loss. So we haven't yet finalised the numbers, but what I'm wanting to see in there is something that says, for every 1% of clinical activity we deliver, we're going to hold ourselves to account to only grow our workforce by something less than 1%. So we're still to do that, and that's what I referred to earlier on about having the financial strategy agreed first. So at the point we've understood our financial trajectory, that enables us to work out how we need to use our workforce differently. But what you'll also see is a lot in the narrative around us being quite challenging of all the professions about getting to a point where people only do what they need to do. And we've got examples, for example, in North Devon, where we've actually moved work that was done by doctors at one point to now using allied health professions and in a very safe clinical way. So the route for me to productivity is to have a real hard look at what are you doing, and could someone else do that?
Thank you. I'm very conscious of time, so what I'm going to ask colleagues to do is be really brief if they could with their questions. I'm going to take all three. I've got Hisham, Sheena and Andrew. So Hisham, Khalil first.
Thank you very much. Just Paul, specifically on productivity and the skill mix of the workforce, you've touched upon it. Are there specific plans for training, retraining, so that there is a generic workforce that can deliver the vast majority of the healthcare functions, and only the specialised workforce for the very specific functions? I'll just try to make it very brief. Thank you.
Yes, you will find that as a major theme in the workforce strategy, yes.
Thank you, and as I say, we will come back to this for much more detailed discussion. So Sheena.
Yes, thanks. A few points. On the front page of the document, where it says, does this have an impact on developing our culture? There's a no. I think this is absolutely central to developing our culture, and I think it should be ticked as yes, because this is, I mean, we've sort of there was a mention of dysfunctional relationships with line managers. I think there is an issue about hierarchies, and if you are doing those dives to understand why people are leaving, we need to be open to the fact that our very hierarchical relationships may be playing a role in morale as well, and how we can actually open up that culture and allow those conversations to happen. The second point has got something to do with really the speed of this. So I appreciate that this is coming in March, but I sort of would have expected in this paper today to see kind of a little bit more of the moving forward. So I think it's become patently obvious that we cannot deal with our organisational challenges by continuing to try to squeeze out productivity savings from our dwindling staff. We need to do things differently. And there's a number of things that we can do for that, and I hope that they'll be coming in the strategy. But I would have liked to see that flagged now. And again, it's the sort of speed of decision making, what evidence will we be gathering about this, about new roles, care coordination roles, using carers and volunteers in different ways, patient activation, and actually the role of digital, which is so critical here. And couldn't we have just mentioned it at this stage? So just a little bit, housing, more flexible time, so many things that are out there in the literature. So also a little bit of reassurance that somebody is looking through this literature and the evidence base as part of their deep dive. And finally, you talked about the wellbeing hub. Are we evaluating its impact? And again, are we actually looking at digital solutions to this? Thanks.
Okay.
Can I just take the last question, then Andrew, and then to respond?
Yeah, thank you, Chair. Yeah, it's not a question. I think in all the discussion around workforce, we shouldn't lose sight of our own staff as well. So I think, Graham, to answer your question, we have exit interviews for everyone who leaves our organisation, and 10% have retired, but actually 30% go and work in other parts of the system. So we've got really in-depth analysis of our staff. Jane mentioned the staff survey. So we continue to do work around that. So we just shouldn't lose sight of our own people.
Thank you, very important point. So Paul, would you like to respond to Sheena's points?
Yeah, so in reverse order, so the Wellbeing Hub, that there is a paper coming to the People and Culture Committee in February that outlines the utilisation and the benefits of the hub. So that will come there, but it's a well-used service, and it's at a pretty reasonable cost per use. So we are hoping and expecting that we continue that into next year. You will see, Sheena, a large feature of the strategy talking about digital and using alternative workforce, particularly the voluntary sector. So I'm hoping and expecting again that when you see it, you'll recognise things that you need to see in there.
Now, Mark, if it's a very quick point, Mark Bryce would like to come in.
Thank you, Chair. Just very quickly, just to reassure members, through the planning process, the key element of focus clearly is on the integration of workforce activity, money and performance. So just to call that out, obviously the work that Jane described earlier. So we are working very closely with Paul across the piece as well. So just to confirm that. Thank you.
Thank you for that point of clarification, and then I think we really do need to move on. The next part of today's meeting comes to the assurance and system oversight section, and Susan Masters is joining us to talk about Torbay Special Educational Needs and Disability Strategy. And it would be helpful as well, Susan, if you just say why it's coming to this board for endorsing.
I will include that indeed. So this is, good morning, it's page 38 to 60 in the pack of the main pack. And this is a co-design strategy that has been developed in Torbay. We've heard a little about this morning already as part of a written statement of action. And there is a request for each partner agency to acknowledge and support the strategy within their respective boards, which is why we are here today. The lead agency for SEND provision is the local authority. So as an ICB, we are statutory partners in the three strategies of Torbay, Devon and Plymouth. As SEND inspections are jointly undertaken by Ofsted and CQC, Local area inspections include clear expectations and of the responsibilities of ICBs, and any improvement plan is jointly overseen by the Department for Further Education and NHS England, with clear governance expectations. So Torbay has had an inadequate rating during an inspection which was undertaken in November 2021, and therefore under the written statement of action this rating comes with additional scrutiny and expectations, including endorsement of a co-produced strategy, which is why this is coming forward at this stage of the improvement journey as an expectation of the local area improvement plan. The strategy sets out, as you will see, the ambitions and priorities on which we want to focus on to achieve them. And as we measure our progress against priorities, we will be continually asking ourselves, as well as children and young people, what difference have we made? The 5 key priorities identified are that SEND is everyone's business, as we've heard a little already this morning, so forgive me if I'm repeating what Hannah's already said. Embedding our values through education, health and social care. Priority 2 is to identify and act on children's needs at the earliest opportunity through valuing lived experience and expertise. Priority 3 is to understand the needs of our children, young people and families, and make sure joint commissioning supports service delivery. Priority 4 is to make sure that all early years providers and mainstream education settings support an inclusive approach to education. And priority 5 is about transition, improving transition planning for young people moving into adulthood. And with each priority, the strategy sets out why is this a priority, why has this been chosen, how will it be implemented, and what will children, young people and families see when it is. We are looking for the ICB, as I've said today, to support the strategy which has been co-produced with families and young people in order to continue that improvement journey. As there is a clear expectation that any local area has a co-produced strategy that is supported by the local authority and the ICB. Hannah stayed with us this morning. Hannah has been instrumental in the development of the strategy, and hopefully between us we can take any questions. Thank you.
Thank you very much. I know Jane wants to come in, Jane Milligan, and then Judy Hargaden.
No, I just wanted to add, I think it's Liz Davenport's not able to be here with us today, but she has been also very involved in this, as well as Melanie Walker. And again, I think it's important, as I say, not to labour the point, but the statutory responsibilities of us, as me as the accountable officer, as well as us as the ICB, is important. The other thing I would say is that we are taking a lot of the learning, I think, Hannah, it's fair to say, from the development of this into Devon at this stage, and obviously working closely with our colleagues in Plymouth as well for any future learning through that. So that was all I wanted to say. Thank you.
Thank you very much. And Judy.
Thank you very much. And I was very pleased to see this, because I know that it's been an issue for some time, and there's some great work here. And I'm so pleased that families have been involved in developing this, because it then makes it more real. If we endorse it, we don't want to be sitting here in a year's time when somebody comes and says nothing has happened. And so I'm wondering if we could have, again, not on the spot, but maybe at our next meeting, some information on how we will fulfill our bits of it, what budgets we have allocated to it, which of our contracts are linked to it, so that actually as we review in a year's time, how are we getting on with this, we knew what we thought we could achieve and what tools we had to do it with, because otherwise it's a statement of motherhood and apple pie.
I think a really important point, Judy. Jane, is that something, or Susan?
Just to say that this strategy, as it's developed by the Family Voice, and so there is a lack of detail around finance in this paper, and that's because any requirement for finance would have to be a separate discussion and a business case to be able to take that forward. This strategy in itself is not an endorsement of a financial investment, so that would need to be a separate discussion.
Yes, I think Judy wanted to
so
come
just
back.
in terms of the implementation of this, I mean, this obviously goes through our children's board, but certainly, Judy, an update on making sure we've got the implementation and delivery plan, as well as how we support it in terms not just about the resourcing, because it's obviously jointly with our local authority colleagues, but also the people to do the doing.
Judy, did you want to come back?
I just want to be picky for a moment. I mean, you're right, Jane, but to say to Susan and colleagues, we can't just endorse a strategy and not discuss how we will make that happen. And I'm not asking about implementation plans in detail. We already spend quite a lot of money in this area. How are we now using our money and contracts and staff differently? Because we've known for a year about these issues. And I think it's helpful for the board, sorry, not trying to shoot the messenger, but as a general discipline, when we endorse a principle or a good way of doing things, and without doubt, what Sarah told us this morning shows that this will be a better way of doing things, we must talk about how we're going to do it, even if it's not in the main paper. That's what I'm asking.
Very important point. Now, I know that Sarah Lou, Sheena and Frank all want to come in. So can I ask you to make your points and then we can have a response to all of them? So I'm going to come to Sarah Lou, Sheena and then Frank.
Yeah, thank you. I'm really excited to see this and that there is some progress. I feel really strongly about priority 2, identify and act on children's needs at the earliest opportunity through lived experience and expertise. Please can we have and families mentioned in there, the impact, and I deliberately didn't question Sarah on it because I think she's been through enough this morning, but we haven't really discussed the impact that this has had on Sarah's life for 15 years and the wider family unit. So I think it's really important that at every stage, I'm sure it's intended, but that it really does need to be thought about the parents and the family around those youngsters as well, please.
Thank you. So if I could bring Sheena and then Frank in, and then we'll have a response to all the points. Thank you, Sheena.
I also really welcome this document. I have similar concerns about the motherhood and apple pie. And on the sections on how do we measure success, I think it was only section 4.4 that had any specific indicators of some suggestion about how you actually evaluate whether this is working. So it's a plea actually to say, can we embed some proper evaluation into this really important development? And can we also sort of embrace an idea that some things might not work, and learning why they don't work and what might work better or how you adapt is actually really important learning to roll out for the system as a whole. So just strengthen the evaluation if we can, please.
Thank you. And Frank?
Thank you. I mean, I think this is incredibly important, and ultimately it's about cultural change. What Sarah's been through and what I've been through and what many other people have been through requires people to be dealt with differently and us to deliver services differently. I think this is brilliant, but my concern is what has already been raised, that the financial pressures the whole system is under at the moment, and the staff pressures the whole system is under at the moment, especially within the SEND service, will impact on that cultural change. So we have to have some way of making the cultural change happen at the coalface with the interactions, despite where we are in terms of the pressures on the staff and especially the pressures on money. Because that ultimately, this cannot be used as a sort of smokescreen for EHCPs disappearing and actually nothing else appearing in its place.
Thank you. There's been a very clear theme on the how and in the financial and workforce context as well. I don't know whether, Susan, you're able to, or Hannah wishes to respond to some of these points, and also to think about the timing for us bringing this back to the board when we can have more detail on those really important how and when questions.
So first of all, just to respond to Sarah Lou, so yes, we can add families in. I'll take that back through the SEM board. That's fine. the measures of success and the evaluation are really critical, and I think some of the work that we talked about this morning has that evaluation built in and is part of this overarching SEND journey. But I will take that point forward back into the tour-based system in terms of further evaluation. For measures, we are working with the local authority at the moment and with the sector-led improvement programme in Torbay to look at how we develop an integrated dashboard for the local authority that will show the impact of the changes that we're making. So not just kind of waiting list numbers, although they are very critically important, but also outcome measures and the impact of what we're doing. I think that in itself is quite a complex piece of work, but like I was saying earlier, I think it would be helpful for us as an ICB to be looking at some of the local authority data and for the local authority to be looking at some of the health data. And so that is a piece of work that's also underway, just to give the board that assurance. The financial and the staff processes and driving culture of change lends itself back to something Judy said earlier about how much energy do we give to saying no and how much energy do we give to changing how we work with families. And in Torbay, that is an enormous focus of the work, and we're about to launch a joint working I can't remember what it's called now, framework, something like that, that is happening, that is launching next week across the integrated local area system, not just in one bit or another. So there's an awful lot. So although this strategy looks like a moment in time, it has been developed alongside a really active programme of improvement that has been driving things forward while the strategy's been being developed. And I agree with Susan that these things, when you write words on a page, sometimes they do feel like they don't have the kind of impact or the kind of measures or assurance behind them that you need to have. But these words are children's and families' words in this strategy, and we wanted to make it something that was short enough and clear enough to be able to be understood by the community.
Thank you very much. So if, as an action, we could add the action to add this to the forward planner and to work with Hannah around timings. Thank you. Thank you very much. And thank you again, Sarah. Going to come on next to item number 9 on the agenda, and that is Anthony Fitzgerald talking about the urgent and elective care recovery. Oh, before we move on, can I just check colleagues are happy to endorse the strategy? Yes, thank you. Thank you. Right, so Anthony.
Certainly. Thank you very much, Chair. I'm not going to talk for very long because I think people have had sight of the paper. However, I have 4 things to mention. First of them is apology for those people with a keen eye. You've noticed that it goes straight to figure 2 in the paper. Figure 1 is quite an important table, and I will make sure that is rectified and recirculated. Figure 1 articulates the core standards and deliverables of the operating plan and the things that we should be adhering to through our improving urgent and emergency care and beyond. And it focuses on a few core things. One is the recovery of services, one is the delivery of the long-term plan, and then thirdly, transforming the NHS. Now, the document that I'll let people read it. We've heard mention already that the current work that's going on in terms of delivering an improvement plan from both finance and performance perspectives. And I'm pleased to say that we've moved from planning to have a plan to actually delivering and, or rather developing that plan. It is quite a complex piece of work because we are trying to make sure that we fully integrate finance, activity and the necessary improvement actions in a context of some very tight timescales. Those are articulated in the paper, not because I want people to be particularly cognizant of the dates, but actually some of the triangulation processes that we are now running through. And there is a team of people that are currently doing that whilst we sit in this room. There are some key challenges, though. There's some key challenges in terms of our providers and their different levels of expectation and delivery, and also some of our demographic challenges across Devon as well. However, I was very pleased to see the improving urgent and emergency care document, because I think actually what it has as its core is simplicity. And in terms of our plans, when I landed in Devon 3 months ago, I was struck by the number of plans that we had. I think I got up to 11 in terms of improving emergency care. And what we will have coming out of this process is a much more stratified and simplified plan that links the finance, the activity and the performance. And that will be coming back to subsequent meetings. The last thing then I wanted to mention was around the governance of all of this. And I think one thing that has struck me and that has struck others in terms of where we are is that we need to strengthen our governance and our accountability around improvement, because it isn't all about spending money. A lot of it is, as we heard this morning, about doing things differently. And some of those are very difficult conversations to have in individual organisations, and also very difficult conversations to have between professional groups as well. And although we have a planned care board, there are some key things missing from that planned care board. Firstly, cancer and diagnostics. And we need to make sure that is an inherent part of that particular grouping. But also then around emergency care and how we focus on that. And although we've had some very good cells focusing on specific things like discharge, some elements of ambulance turnarounds, what we haven't had is an all-encompassing urgent care board. And you'll see within the last page of the paper that we've put together how that would feed in. I'm very pleased that it will have primary care as a key component of that. It will have community care. It will have mental health and learning disabilities. And it will have children and young people. And I think, as we've heard, both in terms of elective care pathways, but certainly urgent and emergency care pathways, we need to make sure that people are very much at that table and it is not dealt with as a separate thing. It is part of our core service offer. 25% of people who attend A&E are actually children, so therefore we need to make sure they're much more at the table than they have done previously. I'm pleased to say that actually the first meeting of the Urgent Care Board will be on the 6th of March. Nigel Aitchison will be chairing that and I'll be co-chairing, and we'll make sure that we've got a very tight but core membership that reflects our system and our challenges, and those particular conversations in terms of making sure the right people are in the room are happening at the moment as well. I'll be very pleased to bring back the developed plans, but as I have said, there is a key challenge for us in terms of the integration and the triangulation of those plans to make sure we're not having separate conversations around the money, the activity and the performance. Thank you.
Thank you very much, Andy. Sarah Lou, I can see. Yes.
A very quick question. Under the children and people being 25%, is that up to the age of 18? And do we know what the figures are for 18 to 25s?
I don't know the figures for 18 to 25, but I'm sure I can find out.
Yeah.
But in terms of your first question, yes, it is.
Okay, brilliant. Thank you. Yes, please.
Thank you. Tracy Lee.
Thanks very much. Absolute music to my ears that we're going to streamline some of those plans and also the governance arrangements, because that clarity on where we're reporting and holding to account, I think, is really, really important. The paper talks about, quite rightly, joint working. But I just want to clarify, because the diagram, the governance diagram on figure 4 on page 70, talks about functions. So I just want to make sure that local authorities are absolutely embedded in the process, particularly because of the changing landscape with locality directors. That's really moving and shifting. So there's always a risk of fragmentation rather than integration.
Particularly around the urgent care element, very much at the table and need to be part of those conversations. And I think in terms of some of the changes with regards to funding, it's more important that that relationship is there and actually that people are participating and actively contributing. So absolutely, that will be happening.
Just to come back, so I think that point around for many local authorities, the route in has been joint funding and joint posts. That landscape is changing slightly for some local authorities, and others we've got a vacant post, for instance, in terms of locality director. So I suppose it's just making sure that whatever comes in its place, that clarity is there. The route in is not now the route that was there.
No, and I think just in response to that, I think it's really important that we're really clarifying how we are working, because joint funding of posts is a mechanism, but it doesn't actually make it happen. So the conversations and the strength of relationship is going to be the important thing.
Thank you. Kevin Orford.
Thank you. Anthony, you and I have had an exchange of emails about some aspects of this, but I thought it might just be useful to rehearse one of these in the meeting itself. So, as you know, I'm really keen that we have an operating plan that this board signs off at the end of March, as do all of the boards across Devon. And I'm just wondering whether this is another plan, which then cuts across the operating plan. I don't think it is, but I think it would just be useful to rehearse how this is aligned to the main operating plan. And then I just have a question on the governance after you've replied to that.
It's one plan to rule them all. One operating plan. Urgent and emergency care is a piece of it, but actually it's only a component in terms of delivery. So it will be one plan.
And but given that the timelines are slightly different, how are we going to manage that?
Well, we've used the time scales first. We started the journey in terms of the operating plan because it was the first off the blocks in terms of time scales. So we have not altered that time scale. In terms of urgent and emergency care, it does dovetail. There's some slight change in dates, but actually, generally speaking, they are the same dates and the same submission templates in many ways as well. That in itself is a good thing, but it's also a bad thing because it doesn't allow perhaps the depth of narrative we would want. But we are using one process. So
I'm just thinking of, to conduct appropriate demand and capacity profiling by April. Are we doing it earlier than April then, if it's going to be reflected?
We're currently doing it as we speak.
Okay. And the governance issue is just, we're saying this is going to go through, when this is done, it's going to go through the Quality and Performance Committee. And I just want to say to the board, I think this is important enough for it to come back here at some point. Absolutely. So that we've got a full board commitment to it. I think it's right it goes through the Quality and Performance Committee first, but I think it needs to come here afterwards. So, thank you.
Thank you. I've got Jane wants to respond to this.
Well, I think because this is absolutely linked to our exit criteria for SOF, I think that elective care, urgent care, leadership and strategy will need to be standing items for our board. Again, not ignoring all the other things, but because of that importance. So, and just picking up Tracy's point about the localities, that absolutely is the underpinning thing. I suppose what we're trying to do is at least align those core elements that actually is once for Devon as opposed to the local piece. The other thing I would say, it's a real challenge to manage the operational day-to-day stuff with the longer-term strategic and improvement piece. And if Nigel was here, he would be saying we mustn't lose sight of the improvement work but at the moment, of course, the operational challenges don't always give us time to have the space to do that. But again, that's another really important plank, and work with Cornwall and Somerset on our with our AHSN, our Academic Health Science Network, it has to be really embedded into that. So that's the other piece of the jigsaw.
And very timely to bring in the voice of Cornwall here. Let's go Kate Shields and then Hisham Khalil.
Thank you. Can I just ask how this interfaces with the Acute Care Collaborative? Because in my head, I'd give elective care to them and say, tell me how you're going to hit the standards, because we'll have RCHT in there, and I know RCHT can't recover on their own. So I just don't know how it comes together.
So certainly those conversations have happened. I think there's as we spoke to, the immediacy of actually getting a plan in and submitted. There are longer term conversations that are going to make a difference in the longer term, and certainly those conversations have started to happen. They are by no means complete. The first draft plan will be circulated and we'll be expecting comments to that. And I had a conversation with Rachel from Cornwall on Friday to talk about how we would share this and then how we'd have a joint conversation and try and bring our submissions together. In terms of the collaborative elements, then it's working on the basis that it's easier to have something on paper to comment on than a blank sheet, and that's what we're trying to do.
Come back, it's just the governance route's different. So I've raised my concerns around the governance of the collaborative and the ICB almost being incidental, where we're trying to avoid soft fall. So elective recovery and UEC are really important. So it's probably outside the meeting, but just to understand the interplay between the various governance routes, that the same things will be managed through.
Yeah, and also then feeding that back through Mental Health Collaborative as well, who are a large component of this and have been actively involved. So it's making sure that's tied up as well, but happy to discuss it afterwards.
Thank you. Andrew, can I check, is a further point to this? Because I know Hisham wants to come into a question, so it is a
It is, it just relates to the governance. Kate's points I think are really important. And we've just started to review all of our governance, and at the moment I think we're up to about 100 different groups in the system, which, you know, no wonder sometimes it takes us a bit of a while to make decisions. And I wonder, Kate, whether we should, and you're probably doing a governance review as well in advance of NHS England's, but I wonder whether we could sort of join up with you a bit on that, because I think the issues will be common, won't they?
Yeah. Thank you. Hisham Khalil.
Just very briefly, Chair, the point has been made that after discussion the quality and performance, it will come to the board, and I think we just need to make absolutely sure that that's done in a timely way so that there isn't a delayed decision, as Andrew just said. Thank you.
Thank you very much, Hisham. So that brings us on to the next item on our agenda, which is the Integrated Quality, Performance and Finance Report. Now, we've been backwards and forwards discussing where this fits in, because we're trying to avoid duplication. There are many items that will go to Quality and Performance and Finance Committee. But what we do want to make sure is that there's room to pick up any points that perhaps aren't raised in either of those committees. So is there anything that either Paul, you would like to say, Paul Renshaw or Susan Masters on this? And, no.
From my perspective, I was just going to say the points I was going to be raising are actually in Hisham's report from the Quality and Performance Committee.
Excellent. So shall we hear from Hisham's committee from Quality and Performance, and then from Finance, and then if anyone has any other items that they feel we've not covered from the IQPR, then we can do that at this point. Thank you very much, Hisham.
Thank you very much, Chair. So I'll be very brief. I think there has been no change in the significant change, that is, in the IQPR in this month compared to the previous one. But the differences, which I think are important to highlight, is that from a quality point of view, we now have the reintroduction of harm reviews, which is a very important quality indicator, and that might have an impact on the recovery plans for elective care. The other thing that we discussed in the committee is the importance of accountability, and the fact that when action plans for certain aspects are not working, at what stage do we say we need to introduce contingency plans or alternative plans, and the role of the system in that. So that's something we discussed at length. There was the issue of the 78-week waits that we would like the opportunity to discuss at a board level because of the implications of that for the system. And we also discussed the two BAF risks that were allocated to the committee, one of them being population health promotion and the prevention agenda. And of course, there could be enabling work that does not have significant financial implications because that is completely going to be linked to the operating plan for this year and the following years. It's in the ICB's chair's report, for example, an area of good practice coming up, which is promoting self-care at home for patients. And it could be a similar thing in terms of the prevention agenda as initiatives that don't cost a lot. And the committee was interested in maybe looking at the BAF risks in its entirety and how the BAF risks allocated to the committee are linked with the other BAF risks in the other committees as well, so that we worked in an integrated fashion. Thank you.
Thank you. Could I just check, are you going to be bringing something to this board for endorsement around your discussions around accountability and next steps?
Yes, Chair. I think we really need a sort of almost like an operating procedure for when we can actually, check the accountability framework that comes to the board, not just raising it to the board, but actually having some more detail to it. And I think that's something we'll discuss in the committee, and we'll bring a proposal to the board about it. Yeah. Thank you.
Thank you very much. Does anyone have any questions? Susan, you mentioned that you had an item. Has that been covered? Thank you. Does anyone else have any questions for Hisham? Nope. Thank you very much. So we're going to come on next to the finance report in that case, and thank you very much. Mark.
Thank you, Chair. I'll take the report as read, but highlight the salient pieces. There's two reports, one for the ICB and obviously one for the ICS. First of all, dealing with the ICB, ICB financial position as at the 31st of December sets out both year-to-date performance and forecast financial position. In summary, we're currently reporting to the end of December £3.1 million surplus and a forecast year-end position of 4.6 surplus. As reported previously, the updated forecast for the ICB sits within an overall amended forecast for the ICS as a whole of 49.5 million deficit. Further discussions are taking place within the system to identify how the ICB surplus may be distributed across the system, and this is expected to conclude shortly. This will of course mean a net neutral change to the system and therefore does not require further permission from NHS England. The ICB has identified risk in delivering the position of circa 18 million, and the report goes on to describe those risks and the actions, including the release of balance sheet flexibilities and the use of non-recurrent funding streams that have been identified to mitigate the risk. The risk then goes on to describe further details on budgets and actual spend and variances, and I won't go through all of those. But in summary then, £3.1 million surplus to the end of December 22 and a forecast at 4.6 currently for the ICB. Just moving on then to the Devon ICS finance report for month 9. Again, we'll assume the report is read. Again, the report identifies the position and the forecast at the end of December and for the year end. And at month 9, the Devon ICS is reporting a year-to-date deficit of 29.3 million, deficit against a planned deficit of 17.4. The forecast deficit, as just previously mentioned, is forecast at 49.5 million, which is 31.3 adverse to plan. The movement in forecast was signed off by the ICB board in December and discussed and agreed at the previous finance committee. Agreement was gained from NHSE to move the forecast and the relevant protocols were followed, with provider boards obviously reviewing and signing off their respective year-end forecasts. The report then goes on to outline the year-to-date and the forecast of the ICS providers in section 2 and is listed. The main area of risks that have not been fully mitigated and contribute to the deterioration of the position are listed in section 3. And it's important to note that the revised forecast deficit is not without risk, and careful management of this is required in quarter 4 to ensure delivery. And the risks are called out as delivery of remaining SIP included within the plans, additional costs associated with winter pressures and surges in COVID and flu, if that were to happen, clearly about workforce backfill, and further inflationary increases and increased utility costs if further cold spells occur. These risks will be managed in a number of ways, and again outlined in the report, obviously liaising very closely with operational colleagues. An assessment of the impact of winter and pressure on urgent care will be provided by COOS and as part of their regular operational update to the Executive Finance and Performance Group. The executive oversight of the financial position will continue at organisational level. The CFOs will continue to meet weekly, and in fact we're in contact virtually daily at this point, where any known variance to forecast will be reviewed and mitigation sought to address anything that goes off track. Membership of the Executive Finance and Performance Group has been expanded to include CEOs, workforce and ACU colleagues, and this will enable a swift response and as appropriate if we begin to deviate from plan. And ultimately, the monthly risk and mitigation process will continue as part of monthly financial reporting to the ICB Finance Committee. And finally, just to call out, a deeper dive into the ICS capital forecast has been started to ensure the system capital spend forecast is achieved by the year end. And to that end, ICB finance professionals are linking in with their provider equivalents and that review will be taken back through the Finance Committee in due course. I'll pause there, Chair. Thank you.
Thank you very much. Do colleagues have any questions on the report? Yes, Tracy.
Just a point, and clearly, given the financial situation, it's really important that no stone is unturned in terms of the reviews that we're doing. But just a word of caution, actually, both for NHS and for local authorities, is in doing that, is to make sure that we continue to have the best solutions at heart rather than cost shunting, and that is always a risk when everybody is under pressure, that we look to see where costs are best pushed rather than making sure that they are the appropriate solutions for people.
Absolutely, agreed. Thank you.
Thank you very much, Tracy. Graham.
Thank you. Can I just ask about capital? Because as colleagues will know, I have a view that we've been underspending as a system of capital for some years, and that's stacking up against us. But when I look at year to date with 30 million under, and yet the forecast is to be 30 million over, there's not a lot of the year left. What do you think is actually happening there?
I think in the past and previous experience, it does, with a great many organisations, appear to spend in the last quarter in that sense. So I think the plan needs to be realigned in that sense in terms of the profile. In that sense, I think what I'm checking at the moment is making sure that there are clear commitments, orders raised, whether it be specialist colleagues coming in and signing off certificates and that sort of thing. So I'm doing all of the detail work through the team. I think a bigger. So I think we're doing all we can to do that, Graham. Yeah.
Thank you. Could I ask a question? And it's around the latest tranche of funding that came down to assist with discharge. And obviously there was a very tight turnaround on that, and quite stringent reporting requirements. Are you able to update us on whether that is being used?
I haven't got the detail.
No.
Sorry.
Perhaps, Anthony, do you have an update on that? No? Okay. Thank you. Thank you. Do colleagues have any other questions? No? Well, thank you very much for that. And that brings us to Kevin Orford and his committee's report.
Thank you. I'll take the report as read, but just highlight that the financial reports which Mark's just taken us through were subject to a good deal of scrutiny at the Finance Committee, and we did receive assurances that processes are in place to actively manage the delivery of the revised forecast for the system at the end of March. And then outside of the finance reports, we had a detailed scrutiny of the processes in place to develop the operational plan for 23-24, and we did as a committee receive assurances on the rigour with which that process is being undertaken this year. Happy to answer any questions if anyone has any.
Any questions from colleagues? No? Thank you very much, Kevin. At this point, we would normally... sorry, Judy, did you have a question?
No, but you said you were going to come back to the performance review for any overview comments.
I do apologise. Thank you very much. Judy, does anybody have anything they would like to raise? Yes, Judy, thank you very much. Thank you.
Sorry.
Apologies.
I could see you were going to the break, and I thought once you'd announced it. It seems to me there's a theme that actually was highlighted in this morning's session that was about how much time of staff gets wasted. And it's come up at other meetings. We've talked about primary care clinicians spending ages managing patients who are waiting for treatments in secondary or tertiary care. The ambulance one really struck me again this month with the increase in the hours. I've got them here if I need them. Of wasted time hanging around outside hospital, and yet all the way through the workforce things, there's initiatives to increase the number of paramedics and to design new schemes to train them, which is great. And so I just wondered, whether that theme of my time is being wasted is one we should use. I was going to push it in Anthony's direction. Every time you're trying to bring together finance, performance and activity, that sort of question about, is what we're doing here wasting people's time? And let alone patients and everyone else, but it's wasting our resources. So there's a theme across all of it, that when we get ourselves into these very difficult situations that happen sometimes, you can end up spending more time on process and less on actually getting out of it.
Absolutely. I think it's a very good point, and I think when we talk about productivity, it's very easy to take that as a negative term, but actually improving productivity is about reducing wasted time. It's, surgeons waiting around in an operating theatre waiting for the patient, for example, ambulance staff waiting outside hospitals. So productivity actually helps us in terms of our overall financial position, because we're not asking for extra money, we're just asking to spend the money we've got more wisely. Now, I appreciate that's a very easy thing to do, but it's a very, very much a core theme to both our financial and performance recovery plans. So yes, it's very much a core tenet.
Thank you. I know Jane wants to come in on this point as well.
I mean, I think Judy might be more familiar in terms of the sort of time to care approach within general practice, literally looking at how that wasted time can be, or the different processes that happen within general practice can be done differently. And I know within Plymouth there are a number of, I'm just trying to remember the name of which practice, it could be Beacon. They've been doing some work on that. I think, but it's a really good point, and almost something that we might need to think about a collective arms, call to arms on. And because I think the problem sometimes is productivity, it doesn't really mean anything to people, but actually looking at time to care is a better handle, and I think that means more to clinicians as well. So, and again, a lot of the get it right first time approach and model hospital, which we also have model general practice or primary care, is very much focused on that. I think what we lack in Devon is and some of the feedback we have been receiving from some of our national colleagues is some of the basics that need to be put in place to support clinicians, and not just clinicians, but all of our staff, to be able to undertake some of that. They're just not there. So there is something about and it does go back to the workforce piece, just really applying some of the basics in terms of rotas, or ensuring if you are a surgeon who's been asked to go to the Nightingale, you've got a badge so you can get in to do the, So I think there's a number of different factors, and it's important, but it's an important point, and I'm sure it's going to be the same issue if we looked at social care, actually. So I'm always up for looking at something that we can grip onto as a sort of a brand almost, that we can apply to lots of different areas. So, and I think time to care is certainly one that's been done successfully elsewhere.
Graham Clark.
Thank you. I think at some point it might be worth returning to the primary care piece, actually, because I think we all recognise that actually it is under a lot of pressure. I think we had a discussion probably the last board about some changes there, given the pressures that they're under. And yet when you read the IPQR, the data itself suggests actually doing rather well, which we know isn't the case, don't we? So just squaring that, I think, would be helpful at some point in the future.
Judy wants to respond.
I think that's because we're only measuring 4 things during the IQPR, whereas we actually have a spreadsheet of this number of measures. So what you measure influences one's understanding. We can, of course, come back to it, but I would just comment that.
Sarah Lou?
Yeah, I just wanted to sort of pick up on the point that Jane made about do it once and get it right. I am going to say again, prevention as well. What can we do about prevention and early intervention, and prioritise that so that actually, that comes under productivity, doesn't it? The more we can do at the beginning, the more we can do early, the more we can prevent, the less we're going to see further up the chain. And I think, we're looking at that so well in certain health areas, but we're not looking at it and we're not prioritising in mental health, and we have to change that.
Thank you, Sarah Lee. Right, what we're going to do now is we're going to come to a very short break, 5 minutes, and then we're going to come back and come on to governance and risk. Thank you very much. So if I could ask you just to reconvene just after 12 o'clock, please. Thank you. Well, thank you very much. So we're going to start now on the governance and risk section, and normally we would have Graham Clark presenting this section, but Graham was away. So Kevin Orford chaired the committee, and thank you very much, Kevin.
Thank you. Apologies that there's no written report, but we met last Wednesday on the 8th of February. There wasn't time to get a report into the board papers on time, so apologies that I'm going to verbally do this. There were 8 things which I think would be useful for the board to know. I will try and do this in the 5 minutes allotted. So first, we received and noted a report on the assurance process which relates to the delegation to the ICB of the podiatry, ophthalmic and dentistry services, which will come to the board at a later date. We also received a report on the progress of the development of the board assurance framework, and we did note for all of our subcommittees that there is further work to be completed on this by the subcommittees, and the audit committee asks that at their next meetings the board subcommittees that have a board assurance risk delegated to them, that they do fully review that risk along with the controls and the assurances in order that the board can sign that off at its meeting in March. We received an update on information governance, and we noted that we're submitting a data protection toolkit submission in June of this year, and a key part of that is ICB compliance with information governance training. At the moment, our compliance amongst our workforce is 34% against a required 95% compliance, which is needed for that submission. So the Audit Committee is urging Executive Director colleagues to pursue the compliance of that within their directorates in order that we can meet that compliance submission in June. Next, we received and approved updates to 6 policies relating to data. So it's the Data Protection Impact Assessment Framework, the Data Protection Framework Strategy, the Confidentiality Data Protection Act Policy, the Safe Haven Policy, the Information Lifecycle Management Policy and the Individual Rights Policy were all approved at the Audit Committee. Next, we reviewed the timeline for the production and the audit of the annual report and accounts. That relates to the 9 months of the ICB, but also the 3 months of the CCG to the end of June last year. We noted that we haven't got all of the guidance that we require at the moment, but we don't think that that's going to delay our timeline, and the Audit Committee was assured that we stand very prepared for the successful delivery of the annual report and accounts. We also heard that we're close to appointing external auditors for the accounts, but that the timing of the audit will need to be agreed with those external auditors once appointed, and that we will, if there's any problems with the timing in terms of the national timescale, that we will need to agree that with the Department of Health. We received a report from the Internal Audit Service, which included 2 audit reviews which have been completed for the ICB. We received an audit on the high-level financial systems, which internal audit rated with significant assurance, and we received a report on conflict of interest at the ICB, which was rated as satisfactory assurance. And the Audit Committee was satisfied that internal audit recommendations relating to those 2 reports have been agreed and are being actioned. And then finally, we just agreed some small changes to the internal audit plan, mainly relating to the board assurance framework and the new timescales that we've got to complete that within the ICB. Sorry, that was a rush through, but I'm happy to answer any questions that anybody has about the Audit Committee meeting.
Thank you. Jane, did you want to?
No, I just
Sorry.
It's quite busy.
Yes, very busy. Any questions to follow up? Well, thank you very much, Kevin. And we're going to come now to Tandy Hara, who's joining us online as committee chair, stood in for Judy, for the committee chair report on the Primary Care Commissioning Transition Committee. Thank you, Tandy.
Yeah, so last time we had the meeting and Judy was not in, so I sort of just stood in for her, so she might as well have some comments on this particular one. But we had presentation from NHSE, Steve Sylvester and Tessa Fielding regarding the position of dental services in Devon. So they just covered the current position, the risks and the main issues, which I'm sure most of you are aware in terms of access, as well as models for delivery for the dentists themselves. And we also, on top of that, did cover issues around we were updated about the asylum seeker new hotel that's been opened again in Exeter, and that the former offer has now gone to Mayflower Group for a 6 months extension. Moving on, Live Well Southwest also agreed that they now sort of processing their transformation plan, and that will be submitted by the 3rd of February. The other update was about Croft or Hall Surgery, who are in the process of changing over providers for Croft from one provider to the next. There were some concerns about whether surgeries have got any sort of say or right in terms of opening or closing their patient list, and whether this is safe, as in, if a surgery wants to close their patient list and they're sort of told they're not going to be able to do that. But we were assured that actually that's all within national guidelines, and all safety aspects are actually considered in that. So the big gift for this meeting was a dental report. I don't know if, Judy, you've had any chance to have a look at the meeting, and if you have any more comments on that.
Thank you for covering it for me, Tandy. I only got back yesterday, so I'm still playing catch up.
Yeah, so that's mainly what we covered. So the dental contract itself is going to be passed over to the ICB very shortly, and that was the whole point of them coming in and updating us on what the challenges are and how we might want to pick it up.
Thank you. Do colleagues have any questions for Tandy? No, thank you. Before we move on, though, I think it would be a really good point to congratulate Mayflower Group on their CQC rating of good. It's an extraordinary turnaround. So congratulations to all of those involved for the extraordinary amount of hard work that's gone into that. So thank you. So and Tandy, I think you're staying on to talk about your other committee, the People and Culture Committee. Thank you.
Yeah, so the People and Culture Committee, a lot of what we talked about has been covered in the earlier report, but I'll just give you a few bits and updates. So on workforce strategy, we are waiting for the workforce strategy draft to come into the next People and Culture Committee, and hopefully that should then come to the ICB for feedback in March. We are expecting the NHS National Workforce Strategy to be published in April, and so hopefully ours should align with that, assuming that that actually comes out on time. But the final narrative and numbers for the workforce strategy should be completed in the first quarter. Workforce planning, again, a lot was covered on that particular one, but I think just attracting your attention to the workforce planning tool, I think, which we talked about in the previous meeting. So we are working on developing a workforce planning tool that should help us with better, to help us to be better able to predict and work out our workforce planning needs depending on what we have on the ground. Now, this we think is going to be a unique tool that hopefully we might be able to let other trusts sort of use, assuming that the pilot goes well. It's been funded by HEE, and we are now proceeding to the procurement stage. Health Education England have given us an analytics apprentice who will start working on this in February, and we expect a full rollout for this during 2023. So that's sort of an interesting piece of work coming up, and we'll be giving you an update on how that goes. Then there's a learning and education strategy. I think we've covered on that particular one as well, but I just want to cover on the element of community upskilling. We've got funding for about £97,000, again from HEE. And this is to support discharge to assess as well as end-of-life care. We're hoping to be able to train and develop some champions within the community and with primary care to help with discharge process as well as end-of-life in hospices. The target is about 600 members from across Devon, 500 online sessions and about 100 train the trainer. So again, this is one of the things that we hope to make a difference in terms of education and strategy. Equality and diversity strategy, again, this is in progress and we're expecting this to come to the committee in March. And then I think after that, you will be able to have sight of it and make comments on that. We've also got social care resourcing. I think we've covered again about the challenges of social care and integrating it and making sure that we're all doing it well. So again, this is work that's ongoing and we expect to have a draft by the end of Q1 with a pilot to go with that. And the business case is also in development. The Wellbeing Hub, again, that was touched on in the other presentation. So we are, again, looking at the business case and hoping that all the providers within will be happy to support us with making sure that this doesn't drop off on the 1st of April when the funding runs out. The use case for it is pretty good. It's been used very well, and we think this will be the wrong time to sort of stop providing this sort of service for our staff. So a recommendation is going to come to the committee in February, and then again after that, hopefully you should be given more updates. Final, it's workforce productivity. Again, I think the other presentation did cover a lot on that particular one in terms of staff turnover, absence, and the fact that we really haven't got a very good idea of why we've got some of these challenges in terms of sickness and absence, but some of them, they're not looking very different from what the national picture is in that sense. So I think that's about it from the People and Culture Committee.
Thank you very much, Tandy. Does anyone have any questions around the table? Oh, Sheena, sorry. Thank you.
Hi, thanks, Tandy. Just a question about the kind of recruitment of overseas staff, I think from two angles. And it's a bit of a tricky one ethically, isn't it? Because we're always concerned about the kind of fact that other countries, sometimes poorer countries, are putting a lot of resource into training people and then we're sort of benefiting from that. So just wanted to raise whether or not we're explicitly addressing those ethical concerns.
Yeah.
And what we might be able to do reciprocally. And the second point about the international staff is that it can be, I think, quite discombobulating to come to a place which has got very high rental and house prices where you don't have family or, you know. And I know that there's a really interesting scheme in Cornwall where it's a London-based charity, but they're linking staff with, for example, older people. So for sort of cheap, free housing, but some sort of mutual benefit, and also this sort of idea. Are we kind of thinking outside the box with regard to these issues?
Yes. So on the ethics issue, there's a whole list of countries that we can recruit from and we can't recruit from. A whole list of countries from Africa that we can't and we don't go out to recruit them. So the majority of the recruitment is from Asia, India, and places like that where we're confident that they do have adequate supply of health staff to come over here. So we are working very hard to make sure that we're not taking nurses away from countries that actually need them. On the second point, yes, there's a whole package and sort of plan that's put in place in terms of supporting people to be able to bed in very carefully and not feel that they've been uprooted from some place and then they're here and nobody is around them. The survey around happiness and staff, I think we've only lost 1 out of 700 so far who had to go back home, but that was to do with family reasons rather than not being able to settle here. But I think that is a very, very important point that we need to make sure that when we're bringing staff here, we not only look after them and help them settle. I think in my view as well is we make sure that actually we're not a transit point where they come here for a year. I mean, they do have 3-year contracts, but we don't really want to be a transit point for other places up north where we've spent a lot of time to bring the staff here. And I think that we need to link this in to their development as well. In my view, is that most of the staff that we're recruiting from outside are actually very ambitious people that want to progress. we don't want them to get stuck in a particular position that has absolutely no clear method of how they'll move on across. I think training is also going to be part of it, as well as moving them on, the ones that come in on social care, having that ambition if they want to become nurses, and we sort of need to be thinking. So there is a lot of thinking outside the box that's happening behind the scenes.
Thank you. I think Paul also wants to add something to this.
Yeah, thank you. Yeah, and also just to reassure you that with the social care recruitment work that we're on with at the moment, we've re-looked at our pastoral care arrangements, because we are conscious that it's a different type of staff group. You know, they're not going to be aligned to big hospitals where, you know, there's potentially going to be people that have sort of joined from overseas in the past. And one thing we are particularly focused in on is the guarantee that there is accommodation for people when they arrive. So, you know, we're going to extraordinary lengths to make sure that the providers that will be receiving these colleagues have got named and post-coded accommodation that they tell us about, and we can get to kind of properly audit, because the last thing any of us want is for people to literally land and have a bad experience. But so far so good. But I mean, a key worker accommodation is something that is on our list of things that we need to start thinking about, because it's, you know, we'd be sat here deluding ourselves if we thought that it's easy to find accommodation in Devon. It's absolutely not.
And we're going to be hearing
Coming back to your point, Sheena, about pairing up with other people. I know HUK do run a really good scheme about pairing, but not with overseas people, but with students who can't afford their accommodation in the city, and they sort of, you know, pair them up with an older person. It works really, really well. So I think maybe that might be something that we might want to consider here as well.
Thank you. Judy wanted to come in.
I just wanted to assure Sheena, I mean, although there's good work going around international development and support for people, Paul will verify that every time he mentions international recruitment, you see he's smiling, I ask him, or we ask him as a committee, about grow your own. Because whilst we have local people who could be, I was about to say the wrong word, who can be grown and supported into great jobs in our health and care sectors, that's obviously the priority we should work on.
Thank you. And I know there's good work that that Tracy Lee has referred to before about what's happening in Plymouth on that score. And perhaps Kate, who's coming next on the agenda for her report on Cornwall and Isles of Scilly, might want to touch on the scheme that was referred to as well. Thank you. Thank you, Kate.
So the report that's in front of you wasn't written by me because I was in India. So I filled it out a little bit more when I was doing my update to our board. So we have the same challenges around performance recovery that Devon has, and we're very conscious that the resources we've got within Cornwall won't ever allow us to have that head start in terms of recovery. So we are looking very clearly at outsourcing and are working with our providers across Cornwall to look at how we make it easy for people to access care in other places, and almost we put the same concierge services in place that the private sector would do to make sure that people feel confident and comfortable to travel. Our workforce is our overriding issue, both for sustainable services and also one of our board members has pointed out that we always talk so negatively about everything that's going on in health and care in Cornwall. It's no surprise no one wants to come and work with us. So perhaps if we were sharing the good news stories, and then people would feel more motivated to come and work with us. We had shared with us a pilot exercise that was done in mid-Cornwall where they didn't ask for CVs. They just said, are you good with people and can you use a computer? Interviewed 90 people, could have appointed them and appointed 18. Mid-Cornwall is a real hotspot for us for no workforce. So we're going to share that with the AHSN and see if we could use it as a pilot for growing our own and growing confidence in people. We talked quite a lot about industrial action, and the chief nurses from both RCHT and CFT and from the ICB are going to do a piece of work around harm, and that's harm to people who haven't had their operation, also harm for staff groups. So it seems clear that industrial action is going to go on longer. We need to make sure we keep teams together, so we've still got that teamwork in wards and at place. So they'll be bringing that piece of work together. And then we talked about our expansion in bedded capacity. The HSJ ran an article yesterday around who had received money and still hadn't managed to increase their beds. Devon looks good, actually. You should be really proud. We reduced our beds by 3%. Our no criteria to reside increased by 3%. But we are working very much with our third sector around dementia, which is a real issue for us, and also discharge to assess in a rural county, and sending you to your own home and having domiciliary care to provide it is quite difficult. And then the last thing that I think would be interesting to share with you is we're talking around how our board's working, and are we really any different from the CCG before, and is the discussion we're having proportionate to the work that we need to do? So we're going to start looking at how we can flip our agendas. So we're doing the statutory accounting for the things that might take us into soft 4, so our elective recovery, are the things people say about us, our money. But then the other month we'll talk about place, because there are so many things happening that we don't tell anybody about. And Cornwall as a county is really quick to say what they're bad at and really slow to celebrate what they're amazing at. And the Somerset article that talks about integrated care at place, we have partnerships that do that. So we just need to be really clear that we can talk about the totality of work across the county. And we're going to review our agendas from that perspective.
Thank you very much, Kate. Does anyone have any questions for Kate? Yes, Sarah Lou. Sorry, Kate, it's not so much a question, just a learning for us. And I 100% think that we do need to celebrate more about the things in Devon that we do well. And I think the suggestion around place is a really interesting one, and somewhere that we can share where some real integrated work is actually happening, and is happening really well. So thank you for bringing that up. Thank you. Jane.
I mean, so Andrew and his team are busy working on that piece around what's good, because it is sometimes quite challenging. And Kate and I attend a South West Chief Execs meeting, which is always interesting, but I'm sitting there thinking, well, we already do this. So we're trying to compile that. I think the other thing to say is that it is really helpful for myself to sit on Kate's board and the other way around, because we do pinch with pride, I think. And also, I'm really keen about the Lost with the GP video, so we'll be looking to see if we can pinch that as well.
He's my GP. I'm so proud of them. It's fab.
Thank you very much for joining us today, Kate. So we're coming on now to the action log. There are 4 items outstanding on the action log, and one of them has a request to close. We've all been very keen to make sure that we follow up on citizen stories that we hear, and we do have a date for following up on our the story that we heard around the asylum seeker programme, and we'll be doing that in May. There are 3 other outstanding actions, and I just wondered whether either Graham or Anthony wish to say anything about theirs. Graham?
Yes, I will. Yes, we pushed this back in discussion with Anne and with Andrew, partly because of the capacity, but more importantly to make sure that we were sequencing that correctly with the governance review and the BAF development piece. But I think we are now looking at a date, and that will include Martin Sykes and Cornwall as well in that session, which we're aiming to have as a face-to-face. So we've just pushed it back a bit.
Yes, thank you for that update. Anthony?
Certainly in terms of the elements here relating specifically to the capacity and demand funding of last year, I was very keen that there was a thorough evaluation of how effective that had been. That's not just about how the money was being spent, but actually what the obstacles were, particularly around virtual beds and virtual wards. So that will be coming, and it will be coming in March.
Thank you very much. So that brings us to the end of that area of business. I'm coming on now to a very important section on questions from members of the public. We haven't received any online questions, but I'm delighted that we're joined in person by Robert Rawlinson. And thank you, because I know that you have a couple of questions you'd like to ask. So do you want to come so that you can use the microphone? If you just press the button in the middle there. Thank you.
Thank you very much, and thank you to the board as well for such a warm welcome. It's often quite daunting as a member of the public coming among such illustrious people, but it's very nice to have had such a welcome and an opportunity to ask a question or two. So I'm Robert Rawlinson. I'm NHS Partnerships Manager at Novo Nordisk with responsibility for the South West region. So, but I am an ex-health service employee. I worked with coronary care and accident emergency and Bristol area for a few years. So, so the questions relate to item 7 in terms of workforce development and the challenges, and also a little bit around the integrated quality performance finance report. So the first bit is in terms of, as an ex-nurse, I remember that one of the things that kept me in role a lot was very much the opportunity to train and develop. And I think perhaps it's one of those areas, because we're so busy operationally getting through the challenges that we've had pre and post-COVID, and obviously, so what sorts of things, and Tandy's partially answered this, but what sorts of things are being put in place and plans in the future to help through investment and development and making people feel that they're growing in their roles rather than necessarily it all being about salary and terms and conditions. So that's one question. Perhaps if I ask both, is that all right? And then the second question is obviously admirable figures around the ARS roles and the fourth best ICB within the UK, England for that. I'm just thinking about, with specificity around ARRS roles, is there any support for PCNs currently in terms of mapping what the relevant ARRS roles they need, which will be different by PCN, to actually enhance that shift that you were talking about in the discussion of relevant work to relevant people, freeing up GP time? Primary care is under huge amounts of pressure. So just wondering what support is offered to identifying what ARRS roles they need to invest in.
Thank you, and that's additional roles in primary care. I should just say, just for anyone who's not familiar with that. Paul, do you want to respond to that?
Yeah, I'll start off. Yeah, thank you. So, I mean, you're absolutely right. It's the one thing that we, in terms of the development aspect, it's the one thing that it's quite easy to overlook, particularly over the last few years when people have been exceptionally busy. So I know through the nursing directorate, for example, we do keep a track on, for example, the CPD funding to make sure that we are using that wisely and effectively. We're re-looking at how we sort of keep in touch, if you like, more formally with people through the whole year. So typically, there's been the kind of appraisal process, which is a kind of twice if you're lucky, once if you're unlucky, sort of set piece event. And through the retention work, we are looking at, formalising a regular catch up with colleagues just to make sure that actually everything's working all right for them. There's no point in having an exit interview really, because it's kind of a bit late at that point. So, particularly with a lens on nursing through the retention work, we are seeking a little and often approach to understanding quite, what people's aspirations are and how we can help them. I think the other bit then is around time, because it's fine having all these plans, but if we haven't got the time for people to, go off and develop, that's a problem. And I come back to the workforce strategy piece really, and as much as I don't think we're convinced at the moment that we've got everything in place to make sure that people are only doing what they can only do. So, again, using nursing as a for example, we know for a fact there's work that goes on in the community through the nursing teams that actually, with some time and attention and through some proper third-party delegations, we could get some social care colleagues to do, which should then free up nursing time to do things that only a nurse can do. And some of that would play into the kind of development time issue. So, a broad answer to a broad question, but it's something we're very conscious about, because clearly it can't be the first thing to drop off the list of things that we give time and attention to. I don't know, Susie, if you want to add anything else from that perspective.
Nothing particularly to add, but just to reiterate that the retention element of that, the CPD strategy as part of the strategy, is really critical to, absolutely, as you have seen in your career, it's critical to people making that decision about when they want to retire, whether they want to stay in role. So there is a lot of emphasis on that, yeah, absolutely.
Thank you, and Judy's keen to come in on the RSS.
Well, just because the relevant executive isn't here, on the additional role schemes, they've been developed by the primary care networks with support from our primary care team. So they do a lot of learning from each other. They've done a lot of thinking about what they want in their patch. There's been a little bit of constraint from the centre as the scheme has developed. And the thing we consider at the Primary Care Committee is making sure that primary care networks that are perhaps more complicated, they might have more practices, they might have diverse communities, that they don't end up losing out on the support they need. So the support is tailored. But the general principle has been to encourage primary care networks, groups of GPs, to take a lead where they can and are happy to, rather than somebody else doing it for them.
Thank you. Oh, Frank.
I'd just like to add to that. I'm a GP, so I work in this field. Primary care knows what will help. The constraints from the centre have meant that we've had to employ people in certain ways. I think each primary care network will adapt to maximise the benefit for their population. And we have been well supported by the primary care team in trying to do that. But it definitely is not a one-size-fits-all. And actually, if there's more freedom to use the funding, it would be used differently.
Well, thank you. So we now come on to any other business. Do colleagues have any other items? No? And so just to say that our next meeting is on the 15th of March, and that will be at County Hall in Exeter. So thank you very much to everybody who's here around the table, online, and members of the public following online as well. So thank you.